Good morning, everyone, and thank you for joining in on our seminar series session today. On behalf of the Georgia Rural Health Innovation Center, our Executive Director, Ms. Glenda Grant, I am pleased to welcome you to the Grantees Positioned for Success seminar series. Simply put, your GPS to success. The purpose of these seminar series are to offer free information to each and every one of you as you prepare to apply for your first grant, or as you continue in your pathway to pursue grant opportunities. We're certainly pleased to have each and every one of you representing all areas of the state of Georgia, all rural counties, some of our staff members who we're pleased to have with us on this morning. This particular month's seminar for the month of March will highlight key considerations for creating robust proposals that maximize the impact of health programming. Our speaker for today is Mr. Chris Scoggins, who will discuss the different levels of intervention, models to conceptualize your program, and ways to effectively convey the plan that you aim to achieve with your program. Mr. Scoggins joined the Georgia Rural Health Innovation Center back in 2019, and since then has served as the Director of Special Projects. In this role, he manages a wide portfolio of initiatives focused on improving health outcomes and delivery in rural communities across Georgia. His background began in a rural county, as he was born in Worth County, Georgia, and received a Bachelor of Science in Psychology degree from Mercer University and a Master's of Public Health from Mercer University School of Medicine. He's a member of the Phi Kappa Phi and Delta Omega Honor Societies, and his areas of interest include health policy, health equity, aging, health workforce, and systems of care. And on this morning, we're pleased to have him as he comes now to present to you an introduction to public health and community impact.
Well, thank you, Dr. Williams, and good morning, everybody. I'm going to go ahead and share my screen, and if I could get a quick thumbs up from somebody letting me know that you're seeing that screen. Excellent. Thank you, Morgan. Well, I also want to welcome all of you to today's presentation. I'm excited to talk to you about this. Public health and population health is a passion of mine. That's something that I hope that's something that you'll see throughout this presentation. I think it's incredibly important to a grantee as they're beginning to conceptualize what their health programming is going to look like and getting ready to apply for that grant. So again, today's session is going to mostly focus on those population health considerations and community impact. So we're kind of taking a step back to before you even apply and really even before you might even start looking for a grant to talk about how do we take that idea or that need in our community and really distill it down into something that's going to be the most effective program that we can possibly execute, and also present it in a way that appeals to those grant makers, that really shows them that you've done your homework and know exactly what you're going to do, and that you are well positioned, as we're talking about today, positioning you for success, making sure that you're well positioned to actually get that grant and be competitive for it. Throughout today's presentation, I welcome questions at any time. Please feel free to unmute and ask a question. We're also monitoring the chat if you would prefer to do that. And I hope to engage you some throughout this and have some conversation. I don't want this to just be a lecture, but I'd like for us to talk about some things and really get your perspectives. I know some of you are currently working on grants. Some of you are intending to apply for them. So let's take this time to discuss some of these issues. So with that, I've set out a couple learning objectives for today. Really want you to get a good understanding of the purpose and domain of public and population health. And I'll use those terms interchangeably today. There are some differences, but for the purposes of our conversation, we're talking about health improvement projects that happen not on the individual scale, but on a larger community and population scale. Also want to understand things like the social determinants of health. I'm going to introduce something called the ecological model of health, the public health pyramid, and talk about the kinds of programmings that we might encounter. And I want to relate all of this back to the grant cycle and that program planning component. Now, those are a lot of jargony terms, and I know the public health and healthcare field in general are full of buzzwords and terms that oftentimes don't mean a very lot. But I hope to break these down and show you their relevance. They're things that I've found to be helpful in my career and with programs that we've been involved in to help conceptualize and really break down the buckets of what we're trying to do. So I always start conversations like this with a very simple question that's deceptively complex. What is health? And I'd love to hear some of your opinions. If anybody would like to unmute or drop something in the chat, tell me what health is to you. I'll also go ahead and tell you up front that I'm very comfortable with long silences.
This is Wanda with Ben Hill County Schools.
Hey, Wanda.
Good morning. When I think of health, I think about like my overall well-being, not just, I'm thinking body, mind, soul, the whole the whole thing. Whether it's good health, bad health, it's just my overall well-being of how I am or how a person actually is.
Great point. And that term well-being is very popular right now, and for good reason. Anyone else who has a thought or comment wants to add to that?
This is Cecil Kilgore with Reach to Teach. When I think of health, I think of, in particular, quality health care, and just being, straightforward with that.
That's an excellent point. We don't just want something. We want something that's high quality, that really is good. Okay. Any other thoughts or comments on that?
This is Judy Sherling.
Hey, Judy.
Sorry for the trouble getting in. My Zoom and Teams don't get along on the same platform.
No worries.
So I had to come in on my phone. But I think of health in terms of a community. I can be healthy, but everyone around me might not be. And I think it behooves us, those of us trying to make improvements to our overall community health, to look at the least served. And we are only as healthy as those who are among us.
I love it. And that goes directly to the point of health equity in a community, that we're only as healthy as our least healthy member, right?
Correct.
Excellent. Well, I can tell this is going to be an excellent conversation because you guys are tracking right with this. So I want to show you this definition. This is the World Health Organization's definition of health. And it's one that we use pretty commonly, that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. When I talk with students a lot of time, the first definition of health that comes up is, well, you're not sick. And that is true, but there's more to it than that. And this definition of health has actually been with us for over 50 years. It's written into the Constitution of the World Health Organization, actually. So for a while, many people have been thinking about health very broadly. And I'd encourage us to take on that definition as we go through our programming individually, and also today as we talk. So the second question I wanted to ask to start us off, what determines our health?
Hey, this is Rachel Shorey.
Hey, Rachel.
Our lifestyle choices, the way we take care of ourselves with what we eat and what we do. Okay,
so food choices, decision-making, behaviors, okay.
Sometimes it's called.
I would say funding also has an impact upon.
Okay, funding, economic implications, okay.
Our genetics.
Okay, I heard genetics, and then Judy, you were going to say something?
Yeah, I was going to say sometimes it's our community environment. We just, we're looking at a health score in our county, and this is Twiggs County, that is 159 out of 159 counties, according to Robert Wood Johnson. But what goes into that score? What makes us such an unhealthy community? Is it cultural upbringing? Is it environmental issues with a rural agricultural society or environment? There are just a lot of factors. I don't think we can pinpoint one single thing.
Yeah, and I agree with you. I see a strong theme in your comments. Community is very strong or very important to you, right?
Yeah.
Good.
Yeah.
And Amy, you're absolutely right too, that genetics, biology, these things certainly impact our health. And yeah, we could be here all day listing factors that can influence our health. But I want to show you this pie chart. It's circulated around, that's kind of changed over the years. Different studies and assessments put different percentages on these different factors, but in general, this is how it breaks down, that our genes and biology do have a role in our health, but they're not nearly as big or absolute as we oftentimes think. You might have a pre-existing inclination toward high cholesterol or breast cancer or something of that nature, but there are a lot of other factors that come into it. Our behaviors and our choices, of course, factor into our health and how healthy we are. And, behavior is very, very complex. It's not always just a simple matter of I choose this versus that. There are a lot of influencing factors there, and we'll talk about that a little bit more later. Of course, the medical care we get, sometimes you need a doctor, you get sick. That's important that you get the care that you need. If you're, have a genetic or biological condition that needs to be treated, you need medical care. But in many assessments and studies, we find that the social and societal characteristics around us account for over half of the health status that we see. You see it said many times in the literature and by many people in the field that your zip code matters more than your genetic code in many places. And that's incredibly true. It's something that we want to pay close attention to. So with those things in mind, I want to tell you a brief story. This is kind of the central parable of all of public and population health, and it really has to do with a river. This is a painting by Claude Monet. He moved out of Paris to the French countryside in 1878 to a small rural community right on the River Seine, and he immediately painted 6 different oils of the river. And I really wanted to put this picture up here to kind of give you some context as we talk through this story. And it goes like this. So 3 friends are walking by a river, beautiful river with a waterfall. And the 3 friends notice that there are children, obviously in distress, floating down the river toward the waterfall. And of course, what do? The first friend jumps in immediately, swims right up to the waterfall and starts yanking children out as quickly as possible, getting them to safety. The second friend holds back, cobbles together some wood and some twine, and creates a raft and starts going across the river, collecting as many people as possible, getting them to the other side. And in their haste, they lose track of the third friend. And that third friend is nowhere to be seen. And they finally look up, and that friend is swimming frantically up the river. And they yell to the friend and they say, "What are you doing? This is crazy. Come back and help us save these people." And the friend says, "No, I'm going up the stream to figure out why they're falling in and to stop it." And this is ultimately how we kind of conceptualize the different areas that we can intervene in a problem. That first friend is the interventional cardiologist. They're the trauma surgeon. They're the oncologist. These are people we definitely need who spend their time making sure that we pull people back from the edge when they get there. We need those people desperately in our healthcare system. The second rung, that second friend, is the primary care doctor, the nurse practitioner, the dentist, who are taking care of the long-term needs a little bit further, trying to prevent people from getting right to the edge. And those are incredibly important people. But the person in our healthcare system that we often lack, and the area where public and population health resides, is that third friend who swims up the river to figure out why people are falling in. And that's incredibly important. And I feel like a lot of our projects that we propose for grant funding fall into that category. We're trying to get up and above where people need drastic intervention so that we can change the course of a life, change the course of a disease much earlier on. So again, when we think about population and public health, we think about the population level, as we say right here in the name. We're looking at how do we impact not just the trajectory of one individual, their life and their disease process, but how do we impact a whole population? So it's kind of dental care versus fluoridated water kind of thing. We want to influence as many people as possible with our interventions. There's a focus on prevention, that prevention is always preferable to cure, that we want to make sure that, we don't let people get to the edge of that waterfall in our metaphor earlier. And we want to focus on health promotion, not just addressing the deficits we see, but actually trying to get people to a high level of functioning and health. Now, there's a lot of overlap between these different areas. I don't mean to in any way diminish the contributions of modern medicine, which are profound, let me tell you. But this is a slightly different way of thinking about it. And I'm glad to say we have many, many health providers who are a part of this population and public health movement to try and make sure that we intervene as early as possible. But this is the context in which we try and place many of the programs that you're working on. Many of your ideas fall within this category. So what then do we act upon when we have our programs and ideas? Oh, pardon me, I forgot. This is a statement that the American Public Health Association put out that I think really nicely defines the scope of practice that we're talking about, where we're actually trying to protect health, promote health, and we're focusing on where people live, learn, work, and play in their real lives, not just in the clinic setting, but influencing day-to-day life when people are not having to go see the doctor, to give them the best possible chance of not having long-term negative health outcomes. So a concept you've probably heard floating around in some areas is this idea of the social determinants of health. And this is really kind of the bread and butter of where population health dwells and where we try and work. These are those factors that are societally determined or socially determined that influence a person's health. Now, these factors are endless. And like I said earlier, we could sit here all day and talk about different factors, but generally, we accept that there are 5 broad categories. Access to healthcare. So certainly one thing that can determine your health is whether you can get to healthcare, doctors, nurses when you need them. If you're in a car accident, your access to healthcare, how far a hospital is from you, certainly determines your health and the outcome that you might experience. Also, your neighborhood, where you live, your environment. Right now, there's been a lot of talk in Atlanta about the acceptable lead standards that the state of Georgia has. Certainly, if you're a child growing up in a home that has a lot of lead exposure, that has a big impact on your long-term health. Likewise, whether you grow up in a place that has tree cover, sidewalks, parks, the ability to get outside impacts your health. Social and community context. There are a lot of things that go into this. We talk about the impact of class, race, ability, all of these things that are kind of socially determined that we've kind of carved people into categories for have a real impact on our health. The idea of rural versus urban fits into this category, these socially defined contexts. We talked earlier, somebody mentioned economic stability, income, and the stability of income has a whole lot to do with health. There have been reams of papers published on the relationship between health and income, because it really does touch a lot of these other issues: your ability to have safe housing, your ability to have health insurance, your ability to provide adequate resources for yourself and children and others. And of course, education fits into that as well. Access to good quality education ripples through that whole system, and we see the health benefits of education across many, many categories. So as you think about your program, think about where it may fit into some of these factors. Maybe your particular program focuses on getting people access to early screening for something like diabetes or colorectal cancer or lung cancer, and that deals with access to healthcare. Maybe we're actually interested in making sure that people have access to safe and attractive parks within our community so that they can get outside and exercise more, and we're thinking about neighborhood factors. Again, as you think through what you're doing, try and figure out where you're talking about intervening. This also fits nicely into another concept that we call the socio-ecological model of health. And that is a mouthful, and it's really not that complicated. As everything we do in academia, it's not as complicated as it sounds. All we're saying here is that no individual is an island unto themselves. Individuals exist in families, families exist in communities, and communities exist in societies. And there are varying levels of influence that ripple back and forth. So if we're targeting an individual, let's say we have a program that we want to implement that has to do with diabetes and education for people with diabetes. And we're going to target the individual. Sorry about that, got muted for a second. But we're going to target the individual level, and we're going to try and educate people about diabetes and appropriate diabetes care and quality food and nutrition. That might work for that individual. That individual might have increased knowledge and intent to act on that. But if their immediate environment, their family and friends are not supportive of that change, if the community does not provide for adequate access to affordable, healthy food options, and at the societal level, we have systems in place that subsidize poor food choices and highly processed, high-calorie options, it becomes more difficult for that individual to act upon those changes that we've convinced them are necessary. So as we plan our interventions, we need to think about those ripples. Maybe to get this individual to change the trajectory of their diabetes, we need to focus on them, but we also need to focus on their family. Maybe we need to focus on some particular elements within the community that we can either increase resources or decrease barriers so that they can act upon what we're trying to accomplish. And again, the name is unwieldy, but it's really a simple, straightforward concept. And it's something that you see throughout the literature, and a lot of different entities use this. And so don't let words like this and terms and models like this scare you when you see them. They really do boil down to pretty simple things. So one thing that's become popular over the past decade or so is something we call the public health pyramid. By show of hands, who remembers the food pyramid that was put out years and years ago? Yeah. It was absolutely criminal that they told you needed 8 servings of white bread a day. It was so it was so far off of what we know now. And the public health folks have really stopped using that and kind of shoved it off to the side. But the idea of the public health pyramid kind of uses that same idea, that there's a structure to and hierarchy to the ways we can intervene and the levels at which we can do things. This was popularized by Thomas Frieden, who used to be director of the CDC, in a paper he published in 2010. And it's been built upon and added to since. But basically, as you go up the pyramid, the focus on the individual becomes greater. The effort needed to affect one individual's health is greater. And as you go down the pyramid, you get a greater, broader population effect. So, for instance, counseling and education for people who already have a disease or some kind of condition about how they can manage and make choices and have some impact over their condition is at the very top. It's very singular to an individual. It takes a lot of time and effort and resources to do that kind of intervention, and it really only affects that person. We come down a level and we start talking about clinical interventions, and these are heart stents, these are surgeries, these are well care visits, these are things that we do in a clinic setting. And really the entirety of our healthcare infrastructure, hospitals, clinics, FQHCs, all of this stuff that we really see first and foremost as the healthcare system fits in those top two levels. But as you keep going down, you realize that there are other things that other levels at which we can intervene. And those levels of intervention are where, public and population health tends to go immediately. Now, again, those lines aren't always the case. Public health is often involved in clinical interventions. Clinical folks are often involved at more basic levels of intervention, but generally speaking, a lot of what your ideas, the things that you're looking at implementing and getting funded will fall into those other levels. So long-lasting protective interventions, vaccines, screenings, community education, smoking cessation, these kinds of things support and diminish the need for those clinical interventions later on. Changing the context of an individual's surroundings so that it's easy to make healthy decisions. Out of my personal experience, I have a toddler at home, and every day when I have to go home, I drive past a McDonald's, and it is really easy to go through that drive-through as opposed to go home and cook something, because inevitably somebody's crying and something's going on and this, that, and the other. So in that case, the default choice, the easier choice for me, is not the healthy one. And what we're talking about is not necessarily tearing down McDonald's and moving them around, but trying to come up with ways that we can make it easier for people to get to the healthy choice, easier to access good quality food, easier to access screening, easier to find smoking cessation help and products. These are the kind of things that we want to talk about, and they support the level above them. And the last one is kind of the most grandiose of them all. And this is really where we talk about societal factors. This is really the realm of health policy. So again, I was talking to you a little bit earlier about the bill that's going through the state legislature now about lead. This is where we as a society come together at the legislative and policy level and say, we're going to make a change when it comes to something like lead. When lead was taken out of gasoline, when lead was taken out of paint, these were large decisions made on the policy level that had a profound impact. But that's a pretty big level. Most of us, I know certainly I, don't have the ear of a lot of those folks. So that might be a little out of reach for some of us. But on the local scale, as we talk with our local elected officials who are our friends, neighbors, and coworkers, sometimes those policy changes are possible. So a couple ways that we think about impacting health. Health programming often takes a few forms. Education, first and foremost. These are pretty often things that we turn to. We want to do a class on healthy cooking. We want to do a class on diabetes management and care. We want to educate teens about the dangers of texting and driving. These kinds of interventions are pretty readily available and easy to kind of get our minds around why and how they are effective. Screening opportunities, increasing screening for cancer, screening for different disorders and diseases, taking preventative measures, vaccination, looking at things like fluoride in the water, implementing safer streets that reduce automobile accidents. These kinds of preventative measures are also targets for many programs. Also, direct service is in there as well. Sometimes the solution to the problem you may have identified is to get a healthcare provider in there to provide a service directly, or to provide direct food assistance or direct housing assistance in certain areas. Those kind of direct services are also very important. And last, as I talked about earlier, policy can be the target of some of our goals. If we've identified something that really is only remedied at policy level, then our intervention might look different and might be targeted there specifically. I also would encourage you, as you're thinking through your programs, we're not alone. And a lot of people across the country have similar issues. Now, they don't have the exact issue. They're not in Twiggs County in particular, and with all the individual nuances of that community. But a lot of times people have addressed some of these problems before, and there are a lot of really great resources out there that have toolkits and descriptions of programs that have been effective. I've called out a few here. I mean, the CDC has ridiculous amounts of information on programs that they've implemented or they've funded in the past. Rural Health Information Hub is one of my favorite resources. They have very easily digestible information about any number of topics. Rural Health Research Gateway makes available all of the interventions that happen under their umbrella and under the HRSA funded umbrella to give you an insight into what other people have already done. Of course, the National Institutes of Health does the same. And I guarantee you, the people at these organizations have a lot more time and money to devote to this than any of us do. So they've done that work for us. And it's really great to be able to use those resources and not have to go all the way back to the beginning. If you have an idea of what needs to be done, and you have an idea of what you think you want to do to address it, you can go to some of these resources and find, plug and play programs that with a little bit of tweaking could be applicable to your community. It also helps you from a funding perspective when you are ready to apply for that grant. If you can base your intervention in something that's been proven to work, those funders are going to say, it's not a risky bet. This is something that has worked before. They have a good plan, and this is something that's going to be a sure thing. And that's what we want them to think when they see your application is, this is a sure bet and money well spent. Another thing that really often kind of causes people to clam up when it gets to the grant application is thinking about things like causal models and logic models. All of these grants ask for these things. And it really doesn't have to be that complicated. We can really break it down. Because at this point, if you've thought through your problem, you know what your problem is, you have an idea what you want to do, you may have found some similar programs that have worked in the past, then we just have to do a bunch of if-thens. So with the typical causal model that you see in a lot of grants, you would take into account things like pre-existing circumstances. What are things that have been existing in the community for a long time? What are things that are just there? Maybe our community has a history of poverty, a history of unaffordable housing. Maybe our community has poor food access. And then we get into, well, what are some of the root causes of the problem we're seeing, that health outcome that we're most concerned about over here? And if this, for instance, is diabetes, let's say, maybe that cause, is, lack of exercise, lack of healthy food, et cetera, goes into this causal bucket. So then we have these pre-existing conditions that inform the causes that lead to the health outcome. And that's really all we're laying out in general. And we know that those individual level health outcomes, a person having diabetes leads to a population level impact, that diabetes rate for the entire community. And we would assume that by intervening somewhere along the way, we can reduce the number of people who have something like diabetes, and then the rate within the community goes down. And that's all we're talking about, is that causal structure between those factors. There are two other things that you see often that I know a lot of people find confusing, and a lot of times people include in their causal models things like moderators and mediators. And really, these are things that modify the cause. So something like a moderator might act with or against one of the causes to increase or decrease its effect. So maybe there's the limited availability of healthy food options, and then where there are healthy food options, those organizations don't take WIC. The access to WIC in that environment would moderate that effect. So the two of them together could have a larger health impact than any one of them by itself. Something like a mediator is just an on-off switch. So if it's not there, something doesn't happen. A really good example of this is the idea of violence prevention, that, a variety of causes can be articulated for homicides, which would be the health outcome in this situation, but access to deadly means is a moderator. If it's there, the health outcome occurs. If it's not there, the health outcome doesn't occur. Any number of examples could be given for that, but it's not really, you don't always see mediators and moderators in situations. It's not always relevant to what you're trying to accomplish, but that's something that I know a lot of people kind of get stuck on. The reason I point this out is once you've kind of thought through your particular health outcome, and you've thought through what causes it, what some of the factors are, what some of the modifying factors are, then these are all the places where you could intervene and make a difference. Maybe those pre-existing circumstances like, poverty, access to affordable housing that we talked about before, might not be within the scope of what you're able to do right now with your resources. But maybe modifying one of the causes or modifying one of the mediators or moderators is within your ability. So for instance, in our diabetes example earlier, maybe we can't increase with our resources currently, we can't increase access to healthy foods, but maybe we can work to make sure that the people who do sell healthy foods accept WIC. That's something that we can intervene on. And again, once you've laid this out, it really opens up the possibilities for different ways to approach the problem, different ways to have an impact. And a well laid out causal model will immediately signal to a funder that you've thought it through, you know exactly what you want to do, and you know all the factors that surround it. Now, obviously, health is incredibly complex and we can't ever know all the factors, but this is something that signals to them that you're a good bet. You're going to be money well spent. And like I mentioned earlier, a lot of them ask for a logic model, which is, things that we've already talked through. It's just the if-thens. If I have the money, time, facilities, equipment, staff, resources, then I will be able to execute my program. And that program will produce a certain outcome. And then that outcome will ripple. So there'll be short-term effects, there'll be medium-term effects, and there'll be long-term effects from that. And that really goes back to understanding that ecological model and understanding those social determinants, how things ripple through the system. So your program is throwing a pebble in the water, and your funders want to see that you understand where those ripples are going and why you're throwing the pebble in where you are. And of course, we'll make these slides available to you afterwards so you can review, but this is the application of a logic model to an alcohol education program for adolescents. So here you see, if we have the resources that we outlined, then we can do our screening and education. That's going to mean that we screen 250 people. We do 50 of these workshops, et cetera, et cetera. And then that has short, medium, and long-term outcomes for our population. So I definitely want to leave plenty of time for conversation and discussion and questions. But again, just to go back to where we started, I hope you have a good understanding of where public and population health fits and why it's important to interventions like this and why it's important to really creating a good foundation for your grant application and your program. I hope you understand the relevance of the social determinants of health. This really is the bread and butter of where you will be intervening in the healthcare within your community. Again, the ecological model, public health pyramid, these are lofty sounding terms, but they're really simple concepts of really breaking down the problem into digestible pieces and thinking about where our actions actually apply. We talked a little bit about the kinds of programs and how you can find great resources on programs that have already been conducted and have a lot of evidence behind them, so that you can invest your program in something that you have a good chance of being successful in. And again, we've related it back to those portions of the grant cycle where we can actually outline for our grantors that we've thought it through and we have a plan for how we're going to go about this, and we know how it's going to impact the outcomes within our community. With that, I do want to open it up for questions. And while you're welcome to drop any questions in the chat, I don't see any currently. You're also welcome to unmute and discuss. Happy to answer any questions. And I'm going to also put up while we have questions and conversation, I'm going to put up my contact information because I do want you to feel free to reach out to me at any time. Of course, we at the Georgia Rural Health Innovation Center are happy to help you along your journey, and we want individuals within rural communities to be successful grant applicants because we know we desperately need resources and we need to be able to implement these good ideas that you guys have about how you're going to impact your community. So with that, I'll take a break and I'll answer any questions if there are some.
Chris, hi, this is Jarling in Twiggs County.
Hey, Judy.
Sort of in general planning, is this grant best used for something tangible that we could put a plaque on and it becomes a sort of a part of a
facility, or is this program funded?
So I think it depends. I'm gonna speak in general. So I think it depends entirely on the identified health issue. I mean,
Okay.
sometimes an identified problem requires a capital investment. For instance, if the only clinic in town does not have wheelchair accessibility, then we need to make a capital investment in a wheelchair ramp. That's going to increase access for a certain population. There are other times where that particular health outcome might need an educational intervention. It might need a preventive services intervention that's not capital based. And different funders view capital investments differently. I would encourage you to read through the things they've funded in the past to see what kind of things they're actually interested in funding. Also read through their RFPs pretty thoroughly. Some are all for that, some aren't. So I'm not going to give you a definitive answer because it really does depend on what you're trying to accomplish.
Okay, thank you.
Now, from an assessment perspective, the capital investments are really easy to figure out if you're doing it or not, right? Like, it's just a yes or no. Did it get built? Whereas sometimes those educational outcomes are a little harder to ascertain and really measure. Other questions, thoughts, or comments?
You did say that we would be getting a copy of the slides, correct?
Yes, I'm happy to have the slides shared. And Dr. Williams, would you be willing to share those with the group?
Yes, most definitely.
Yeah. Okay. Well, again, my contact information is there. It'll be in the slides. If you have questions after we get off the call today, please feel free to reach out to me. I know Dr. Williams is always available as well. But I really appreciate your time today. Appreciate you logging in and here if you have any questions. But thank you again for your time, and I'll turn it back over to Dr. Williams.
All right, thank you so much, Chris. You all forgive me. We are on a first name basis here at the center, but Chris, you did a phenomenal job. Certainly very informative presentation and highlighting and connecting how public health relates to grant program development and implementation. So thank you so very much again for the information that you shared in our first seminar of this seminar series. And we hope that all of you all that are present receive something from it that you can take back as you develop your programs and your proposals in preparation to receive more funding. I do want to just briefly share some information with you all so that you can see this. I'm making it bigger now. Okay, so hopefully you all can see that. This is the list of the additional seminars that make up the GPS seminar series. As you can see, we will host a seminar once a month on the second Tuesday of each month. So please make note of these dates, the same time each month at 11 a.m. And you also can go to our website, georgiaruralhealth.org/grant-program/ to register for any and all of these remaining sessions. So please, ma'am, please, sir, make sure that you register in advance. And much like with this session, you'll receive information the day before on how you can join via Zoom and see who our guest speaker will be for that particular session. Okay. But if nothing else, thank you all so very much for joining. We hope that you have a wonderful afternoon. Enjoy lunch and have an awesome day and awesome week. You all take care.
Thank you.
Thanks, everyone.
Thank you.
You're welcome.